thank you very much for the invitation. I'm quite honored to give this relatively short talk on treatment of pain in our clinic. I would like to start with my conflicts. I have a strategic collaboration with the FDA on opioids and antidepressants. We're performing studies together, as well as with NIDA. I didn't put that on. I have some grants from companies, as you can see here, and I'm active in several journals, as you can see at the bottom. Well, our pain clinic, and I wrote this presentation together with Marieke Niesters, who is the head of our pain clinic. It relates to treatment of chronic pain. We also have a separate unit that takes care of acute pain, while the chronic pain clinic is headed by a physician and also staffed by physicians. Acute pain is predominantly staffed by anesthesia nurses. Well, I had research. I do not only do pain research. I'm originally a physiologist, but research in our hands relates to, and the talk will be today on acute pain and chronic pain. And what we now try to do, especially in acute pain, I try to include almost all patients in at least one pain protocol. What we intend to do is, I think, quite common in all pain clinics, and not only ours. We have an initial triage, we have a visit to the clinic of the patient, relatively a long period, around 1 hour. We have multidisciplinary consultations. Then it's followed by shared decision-making, treatment, the wait and see possibility, the intervention pharmacology. I will get back to that. And what do you do next with the patient? You can review and reconsider, but you can also send the patient back to either the GP or the medical specialist that is involved in the first consultation with the patient. Well, I will shortly give you one example of a patient that I was introduced to just recently. It's a 45-year-old woman who came to us because of several sensations in her jaw. I would call that neuropathic symptoms. I wouldn't call it pain at all, possibly even phantom symptoms, but extremely debilitating. And it occurs a year after removal of a tumor of the jaw. The tumor went from the tooth, initiated in the tooth, and it was quite debilitating. And she's, for example, in step 1. Well, she went through triage. She will come soon to us, and we will hopefully be able to help her. Well, this is a typical patient that I see. I often see patients together with the neurosurgical department, patients that have either severe neuropathic pain symptoms or symptoms that nobody can place. The GP had no idea, and she had been to 2 other pain clinics that also had no idea what to do. Well, in our treatment, we have several pharmacological treatments, and I know this is quite common to all pain clinics, but there are 1 or 2 specialties that I would like to mention here. That, of course, you need to realize that there are several forms of pain, nociceptive, neuropathic, and I think you all know the medications that I've shown you here, and for the different forms of pain. And most pain syndromes might be considered, for instance, cancer pain, a mixed form of nociceptive and neuropathic, but evidently we have visceral pain, ischemic pain. We made a choice recently not to treat patients with oxycodone anymore, but we switched, not only in the pain clinic, but in the whole hospital, towards tapentadol. And I have to say, we had until recently 80 protocols that dealt with pain treatment in different departments. Well, Marieke Niesters took care of that, and currently we only have 3 protocols for the whole hospital: acute pain, chronic pain, and cancer or palliative care, cancer pain or palliative care. And one of the main changes that we made is we switched from oxycodone that was commonly prescribed in our hospital, also post-operatively, to tapentadol. Tapentadol, it's not a new opioid. You all might know it. I do not know, but it has a special property that it's, apart from a mu opioid receptor agonist, it's also an NRI, a norepinephrine, noradrenaline reuptake inhibitor. It has 50-fold less affinity for the mu opioid receptor than morphine. So it has a relatively low opioid load, but its synergistic interaction with the NRI concept causes potent analgesia. And I will give 2 examples at the end of my talk of studies in which we show the efficacy of tapentadol. So this is a typical pharmacological approach that will be common to all pain clinics. And this also is a typical interventional treatment option. I'll show you some of them here. TENS, transcutaneous electrical neurostimulation. I must say it is very popular, also effective. I have experienced myself with it and was extremely effective. We're working a lot with Qutenza, which is a capsaicin patch. I will show you an example of how we deal with that later on. And there's currently a movement going on to move the Qutenza treatment towards first line, or a little bit in between second and first line probably. There are the injections, there's the PRF, evidently the neuromodulation, and the possibility of surgery. Our neurosurgeon is involved in our pain clinic, and we sometimes perform surgeries, for instance, the excision of neuromas. And evidently in cancer pain, because this relates to non-cancer pain, there are the neurolytic blocks. So it's quite common and nothing special. But what we do in our pain clinic, and the aim is that at one point all patients will be in this pathway, this treatment pathway, is that we do not treat the underlying disease of the patient. And we do not treat the symptoms of the patient, but we believe that we should treat the phenotype of the patient. And to determine phenotype, we have made several changes to our pain clinic. We always have had quantitative sensory testing. I will not really discuss that today. But what we now have in our pain clinic is a room with a microscope, a cornea confocal microscope. And patients that we feel fit can go in there and we can determine the presence or absence and the severity of small fiber neuropathy. And I will come back to that later. Evidently, we have questionnaires, but we now also have possibilities to test endogenous pain modulation, such as conditioned pain modulation and offset analgesia. And I will discuss offset analgesia a bit later because it's so easy to perform these tests and give you so much information regarding the presence of sensitization, segmental sensitization, etc. It is quite interesting to discuss that possibly later this afternoon. So, you know, if you do this phenotyping concept, you will see that your patient might have specific symptoms, specific abnormalities, and that every patient will be very, very different. For instance, there might be sheet intolerance in your patient, a sign of allodynia or not. He might have effective conditioned pain modulation or effective offset analgesia or not, signs of endogenous pain modulation. He might have signs of central or segmental sensitization. We're especially keen nowadays to look at segmental sensitization by performing temporal summation. In animals, you call that wind up at several locations of the body. And like I said before, we now have the option to detect abnormalities in the small fibers that are superficially present on the body. And let's have a look at that, the small fiber neuropathy. Because surprisingly, many of our patients do have a small fiber neuropathy, depending a little bit on the disease, the underlying process, but even in diseases processes where you would not have expected it, you do see small fiber neuropathy. Well, beforehand, we would take skin biopsies to determine the level of neuropathy in your patient. This is, for instance, a skin biopsy of a normal patient. You can see here, I hope you can see my mouse. This is basal membrane. Here you can see the large nerve that sprouts, the C fibers, and you can see plenty of C fibers here in this normal individual. But like I said, we now moved towards the cornea. Here you can see on the left, evidently a cornea. Here you see also the cornea, and you can see here the layer, we call that the Bowman layer, that has a whole plexus of nerves. We call them the nerve plexus, but this is the location of these C fibers. And it's extremely easy to determine the C fiber status through the cornea. I'll give you an example here. On top right, you see Monique van Velzen, our postdoc and specialist in the microscopy, the CCM, with a patient that is looking into the microscope, and she takes a picture. And you can see here an example of a normal individual. This is a normal cornea on the left side. You can see the C fibers quite clearly. And we're looking at the length of the fibers, the density of the fibers, and the branching. And I look the most at branching. The more branching, the healthier the cornea, the healthier the C fibers. And what you see on the right side is the world. This is the complete cornea, but we take only a sample. And this takes you about 2 to 3 minutes. And the measurement is also done within not the measurement, but the calculation of the C fiber status, I have to say. So it gives you a lot of information in a very short period of time. And to give you an example, again, this is a patient on the bottom, on top, the same figure as I showed you before, a normal skin biopsy. And in the bottom, you see a patient with neuropathy related to his sarcoidosis. Sarcoidosis is a lung disease, but in 50% of patients with sarcoidosis, there is a neuropathic pain problem. And we've done many, many studies in these patients. We've treated them beforehand with anti-inflammatory medication. I will not discuss that now, but you can see here, this is a sample of this patient, of a patient with sarcoidosis and small fiber neuropathy. Again, you see the larger nerve, but you see there's little to no sprouting, a few fibers present. Really, really typical for small fiber neuropathy. But what's so problematic with these skin biopsies that it takes a very long time before you have the result, and sometimes you miss the nerves by just not taking biopsies at the right place. You never know that before. Here is an example of this same patient on the right side. Again, the normal one on top, a normal subject. On the right side, a patient with sarcoidosis. And you can see that there are areas with no fibers. You see a few fibers, little to no branching. And we, in the meantime, have done so many patients that we now have normal values from our lab. They compare quite well with the literature. But you can see, again, these are sarcoidosis patients. They have reduced cornea fiber density, and they also have reduced cornea fiber length. So these are typical patients with small fiber neuropathy. You can see that the spread is large. That's absolutely logical. But these are abnormal patients with complaints, several symptoms of neuropathic pain. Well, I would like to move now to a second test that we perform in our clinic, especially related to research, and that's offset analgesia. We've done many studies on offset analgesia, and you can see here it's performed with a thermal system that applies heat to the skin. And the dotted line is the temperature. You can see that the temperature increases. We keep it constant for 5 seconds, increase it by 1 degree for 5 seconds, go back, keep it constant for 20 seconds. And you can see in red the electronic VAS score of the patient. So he feels pain, he or she. The second stimulus, the 1 degree increase, again pain, but the drop of 1 degree Celsius causes a severe analgesic response. And that's what we call offset analgesia. Simple to perform, but gives you lots of information. I will show you that later. And this decrease in perception, in sensation, is not that easy to understand where it is generated. And we now have proved that there are 3 steps involved, 3 locations, the skin, the spinal cord, and the brain, and that all need to be intact to get this kind of response. If you have a patient with, for instance, diabetes and neuropathic pain, you will see that the response is very different. There's no offset in the VAS score. Here on top, again, you can see the initial increase in VAS score, the second one, but when you decrease your thermal stimulus, there's little to no analgesic effect. There's a small, what we now call adaptation, which is normal, happens to everyone, but there is no analgesic response. And we've looked in all ages, even in children. We've done a large study in children from 7 years on. Everybody that we tested without neuropathic pain had a normal offset analgesia response. Only people that had abnormalities in their nerves or spinal cord or centrally, so it's also a sign of central sensitization, had this abnormal response. And we performed an ROC analysis, and you can see that sensitivity and specificity of this response is quite high. So we use it now to determine the endogenous analgesia state of our patients, we use it next to CPM. Now, just to show you that this is quite of value, I show you 3 diseases that are associated with pain. We have type 2 diabetes, sarcoidosis, fibromyalgia. They have all a very, very, very different origin of the underlying pain syndrome. But if you look at the phenotypes of these patients, for instance, on top, you have patients that have a normal cornea nerve fiber state. On the bottom, they have an abnormal state. Here we have signs of central sensitization, again, measured through CPM or offset analgesia, or they have signs of central sensitization, meaning if we talk about central sensitization, that these abnormalities occur on different sides of the body, not just on one side. But if you look all over, you can see that the occurrences of these phenotypes are quite common across painful states. And we believe that you should not treat your patient vertically, but you should treat them horizontally. You should look at the phenotype of your patient, and it doesn't matter if it's a patient with fibromyalgia or type 2 diabetes or sarcoidosis or PHN or whatever. Treat them horizontally and not vertically. You can see that more or less the distribution of these phenotypes across diseases is similar. That's, for us, it was quite surprising. Now let's go back to earlier studies that we performed. This is a study in which we looked at treatment of patients with post-herpetic neuralgia and capsaicin patch. As you can see, we have on top here the capsaicin active placebo, 0.04%, and here we have the 8%. And we looked at subgroups. And we discovered that some patients did not respond to treatment, others had a very short period of response, others had a mediocre, moderate response, and some had a large response. We call the last one on the right side the super responders. But what is so interesting, there are 2 things that are quite interesting. The placebo response was almost as effective as the active treatment. By the way, this was a study performed together with Astellas, and Astellas is quite also, at the time, was interested also in the placebo patch. But what is most interesting, that we coupled these responder groups, we coupled them to the phenotype of the patient and to specific risk factors. We now call them risk factors because we want to relate them to disease. And what is quite important is, I give you 2 examples. If we had a patient that had prior to treatment a variable pain state, so sometimes in pain, sometimes not, it predicted with high accuracy that this would be a placebo responder. While patients that were on opioids prior to treatment with capsaicin, well, they were what we called at the time lost cases because they almost always fell in subgroups 1 or 2. So you can, with some certainty, but you have to look for it quite meticulously, discover specific risk groups. Now I will show you 2 other studies in which we did phenotyping. This is a population of fibromyalgia patients that were treated again with tapentadol. I spoke about tapentadol before. That tapentadol was developed to increase endogenous pain modulation. So we here have a population of fibromyalgia patients that had either normal cornea confocal microscopy data, so their nerve fiber state was either normal or it was abnormal, and irrespective of the group that they were in, we were able to increase their endogenous pain modulation, as you might expect from a drug like tapentadol, because it's more or less a combination of an opioid and an antidepressant. However, if you had these 2 hits, so if you had abnormalities in your endogenous pain modulation and you had abnormalities in your cornea, so you had small fiber neuropathy, the drug was ineffective in reducing pain. So this is to show you, but by a couple of very simple tests, you can also already decide who to treat with this specific drug. And we have a recent publication that will come out in Pain Reports, I hope before the end of the year, in which we did not look to fibromyalgia patients, but we looked to patients with chronic low back pain. And we again treated these patients with tapentadol. And what we observed was quite interesting, that the majority of these patients, they had segmental sensitization. So they did not have central sensitization. And by the way, in this study, we looked at sensitization by testing for temporal summation. And as you can see on the arm, there was at baseline there was normal temporal summation, and also the drug had no effect. But on the place where the patient was most painful, in the lower back, we did see abnormal temporal summation. And when we treated with tapentadol, we also saw that the central sensitization reverted towards normal values. So again, by performing very simple tests, in this study we tested for CPN and for offset analgesia, and we now can predict, if we do these tests beforehand, who will benefit from tapentadol treatment and who will not. Okay, so I will now discuss some of the new pharmacological options that we have in our clinic. I will discuss only a few of them. I will discuss the biased ligands. What I find myself extremely interesting currently is that we now work with drugs that enhance endogenous pain modulation, but are only effective in individuals that are in pain, that have no effect in individuals without pain, only in pain, and that are also without side effects. And these drugs enhance the efficacy and they reduce the breakdown of endogenous opioids like enkephalines. And we use them currently in a study in perioperative pain. I will talk a little bit on benefit and harm. I have another 8 minutes, and I will talk a little bit in reducing harm so you can increase the dose of your drug to enhance benefit. Well, this quad chart shows you a recent publication on a biased ligand that we performed. This biased ligand is from a company called Trevena. They call their drug oliceridine. A biased ligand is biased towards the G protein coupled system and has little activity at the other pathway, the beta-arrestin pathway, following activation of the mu opioid receptor. It is quite under debate whether this is true, if biased ligands exist, or if we're dealing here with drugs that have a partial agonism. Either way, I'm not really interested currently in the mechanism. I find it highly relevant, of course, but the mechanism per se is not relevant to our study. We initially analyzed some volunteer data, and what we do, we nowadays calculate what we call the utility function. We look at side effects, we look at benefit, and we calculate the probability of benefit minus side effect. And then you get curves like this. And you can see that the oliceridine in blue has a positive utility, so the probability of benefit exceeds the probability of side effects, while a drug like morphine has a negative utility. So it produces analgesia, but the probability of serious side effects is larger than the probability of analgesia. And this, by the way, up till a concentration range of 30-35 nanograms per ml, that's the clinical dose range for clinicians working. We were also able to couple this to patient data. And what we did, we calculated for postoperative patients their utility function over time. You can see that at the bottom. In blue, the oliceridine, in orange, morphine, and in green, by the way, the dosing moments. And these are all PCA, the patient doses himself or herself. But what we observed is that when utilities were below a value of 0.2, the probability of, in this case, we looked at respiratory depression, because in the US, respiratory depression is a serious problem in everywhere where people overdose on opioids, by the way. And you can see here that indeed we observed respiratory events at lower utility values, but you can see that the utility of morphine is extremely negative in this patient, and that also the number of events was higher than in the oliceridine. And this was across all subjects that we tested, and we tested it after major and minor surgery. And this is all in this publication. So this is quite interesting. So we believe this utility function is extremely interesting. The form of the utility function also differs between different side effects, and it also differs between patient populations. So if you have a patient with, for instance, sleep apnea related obstructions, you don't want to give him an opioid that causes obstructions. So for instance, in brown here, that would be a patient like that. You would like to give him a drug with side effects that more in the blue area. So you can play with that. And what's quite interesting, oh, by the way, this is an intermezzo just to show you how we design these utility functions. Normally we do them based on PK/PD modeling. I will show you also an example which you can do it without PK/PD modeling. This is just an example that you can also do this in animal studies. This is a rat study that we did. On the right side, you can see that we now already introduced so-called utility surfaces. They incorporate much more complex interactions, also multiple side effects at the same time. Look at the publications, it's well written therein. But I would like to focus on this one. This is a post-operative patient population treated with fentanyl. And we saw that if we would calculate the utility function, there were two distinct groups. Some subjects were very potent, or some patients had very high analgesic potency, they are in green, and very low side effect potency. Well, the reverse was true for subjects in red. And this really has changed our practice when we saw it. Nowadays, already after a few doses of fentanyl, when we see that the subject has little analgesic effect, but lots of side effects, we switch almost immediately either to another opioid, we rotate to another opioid, or we switch to a whole other design, for instance, ketamine or clonidine. Well, this is to show you that you can also construct these utility surfaces, utility functions by doing Bayesian statistics. You don't need to do PK/PD modeling. Have a look at the paper, you can find it there. Just the last couple of slides are about reducing adverse effects such that you can increase the dose. I will focus here again on respiratory depression. It's not new. It's already 1945 that there was a first publication on this topic in which these researchers showed that by giving amphetamine together with morphine, you reduce the probability of respiratory depression and you can increase your dose. And we're doing that now in our clinic as well. We're looking at respiratory stimulants. On the left top side, you can see that a simple drug like ketamine, by acting at the AMPA receptor system, enhances respiration, allowing you to increase your morphine dose, for instance. On the right side, I show you more or less the same with the BK channel blocker, a potassium channel blocker. That's really, really relevant because it also antagonizes obstructions. It enhances the tone of the muscles of the pharynx. And in the middle bottom, you can see all of the areas in the brainstem involved. Most importantly, you can see that many neuromodulators are involved. So many new drugs will be developed, all aimed, and they will be co-administered with opioids, all aimed at reducing side effects. It not only relates to respiratory depression, it relates to sedation, it relates to arousal, upper airway obstruction, nausea and vomiting, etc., etc. In the US, I have a meeting with NIDA next Tuesday just to talk on this concept because they're extremely interested in what we have done. Well, I think that I'm at the end of my presentation. Thank you all for listening.